Welcome back to the Deep Dive. If you were listening to this right now, you were probably staring at a massive stack of notes, maybe a heavily highlighted textbook, or, maybe you are just on a long commute trying to squeeze in some study time before rounds. We completely know the feeling.
We really do. And the goal here today isn't to just read the textbook to you. It is to take all that dense, let's be honest, often very dry material from the page and turn it into a conversation that actually sticks in your brain.
Exactly. We want to build a mental framework for you, a scaffold, I guess.
Oh.
Because once you have that core structure, all those tiny details, the enzymes, the receptors, the incubation periods, they finally have a place to live.
Right. And today we are tackling an absolute beast of a topic. We're cracking open Murray's medical microbiology, specifically Chapter 52. We are talking about Togaviruses and Flaviviruses.
Yeah, these are definitely heavy hitters. I mean, if you look at human history, very few viral families has caused quite as much misery, panic, and economic devastation as these two.
Oh, absolutely. We are talking about yellow fever, dengue, West Nile, Zika. These are names that genuinely scare people. And for very good reason.
But before we get into the bleeding from the eyes part of the story, we really need to set the stage. If you look at the title of the chapter, it is Togaviruses and Flaviviruses. But out in the hospital on the wards, you rarely hear people actually say, oh, I think this patient has a togavirus infection.
No, you really don't. You will usually hear them categorized by their ecological lifestyle. You'll hear the term arbovirus used all the time.
Which, to me, always sounds like a tree virus.
Yeah.
Arbor.
Yeah, that is a super common mistake, but no. It is an acronym. Arthropod-borne virus. Arbovirus. It is not a taxonomic family at all. It's really more of a job description. It tells you exactly how the virus gets around.
So it's basically nature's delivery service. Mosquitoes and ticks.
Precisely. And that is the unifying theme for about 90% of what we are discussing today. These viruses exist in this incredibly complex web between an invertebrate vector, usually a blood-sucking insect, and a vertebrate host, like a bird, a horse, or a human. We're really just one stop on their loop.
But, and I feel like there is always a but in microbiology just to mess with med students, there is a pretty major exception here.
There is a massive exception. One of the viruses in the togavirus family, which is genetically a togavirus and structurally a togavirus, has completely abandoned the insect lifestyle. It doesn't use mosquitoes. It doesn't care about ticks. It goes human to human entirely via respiratory droplets.
You're talking about rubella.
Rubella, the German measles. So as we go through this, you need to keep that mental split in your head. We have the jungle and swamp group, the arboviruses, and then we have rubella, which is kind of the odd cousin sitting in the corner, behaving exactly like a standard respiratory virus.
Okay, so let's start at the very beginning with the names, because I love the etymology here. Usually the scientists who named these things were actually trying to give us a cheat sheet for the exams. Let's look at togavirus first.
Right, so that comes from the Roman toga, meaning a cloak.
A cloak. Okay, so is that just them being poetic, or does it actually tell me something useful about the viral structure?
Oh, it is highly structural. These are enveloped viruses. But unlike some enveloped viruses where the membrane is sort of loose and baggy, the togavirus envelope is very tight. It is closely associated with the capsid underneath. It's like a tightly fitted cloak.
So it is not like a flowing superhero cape. It is more like...
Shrink wrap. That is the perfect analogy. It is tightly shrink-wrapped right around the internal icosahedral capsid. The glycoproteins essentially anchor into the capsid and pull that lipid membrane taut.
Okay, I like that. So toga equals cloak, which equals shrink wrap. Now, what about Flavivirus?
Flavus is just Latin for yellow.
Which obviously brings us to the most famous member of that family.
Yellow fever, exactly. The virus that famously turns you yellow because it profoundly destroys your liver, causing massive jaundice.
It's really interesting because the Flaviviruses actually used to be classified as togaviruses, right? Like back in the day.
They were, because under an older electron microscope, they look somewhat similar, and they are both positive-sense single-stranded RNA viruses. But as our molecular tools got sharper, we realized the way they actually replicate inside the cell is fundamentally different. So they eventually got kicked out and given their own family, Flaviviridae.
And that new family includes dengue, yellow fever, West Nile, Zika, St. Louis encephalitis, and hepatitis C.
Technically, yes. Hepatitis C and hepatitis G are flaviviruses. However, hep C is such a distinct clinical entity. I mean, it is bloodborne, it's chronic, it doesn't use a vector. So Murray actually separates it out into Chapter 55. For the sake of our sanity today, and to stick strictly to the arbovirus theme, we are going to bench hep C.
Thank goodness. My brain definitely thanks you for that. So we have togas and flavus. Let's get into the hardware of these things. If I am a virus in one of these families, what exactly am I made of?
You basically have three key components. First, right in the center, you have the genetic code, which is single-stranded positive sense RNA.
Let's actually pause right there on positive sense, because I know students constantly mix this up with negative sense. Positive sense basically means it is ready to rock right out of the box, right?
Correct. Positive sense RNA is essentially viral messenger RNA. If you were to take just the naked, purified RNA of a Togavirus or a Flavivirus and inject it straight into a human cell, the cell's ribosomes would look at it and say, oh, I know exactly what this is, and they'd start translating it into viral proteins immediately.
Whereas if it were negative sense, it would just be complete gibberish to the ribosome until the virus converted it.
Exactly. The ribosome wouldn't be able to read negative sense at all. So these positive sense viruses are what we call infectious RNA. That is the core. Surrounding that RNA is a capsid, the protein shell. And surrounding that is the lipid envelope, which is studded with viral glycoproteins.
So they are enveloped positive RNA viruses. The mnemonic I always use to keep them straight is togas are loose cloaks, but flaviviruses are yellow. It just helps anchor the names. But you mentioned earlier that structurally, under the microscope, they actually look quite different from each other. You used the shrink wrap analogy for the togavirus. So what does a flavivirus look like?
If the togavirus is a shrink-wrapped package where you can visibly see the geometric geodetic texture of the capsid jutting out underneath, the flavivirus is much smoother. The envelope proteins, specifically the E proteins, they actually fold over and lie completely flat against the surface of the membrane.
So it doesn't have those typical spikes sticking out all over it.
Not really, no. It doesn't look like a standard coronavirus or influenza with big spikes. Think of a golf ball. It has a tiny bit of texture, but overall it is spherical and relatively smooth. The proteins are interlocking flat against the surface.
Shrink wrap versus golf ball. That's a great visual. Got it. Now, let's talk about the life cycle, because this is where Murray gets incredibly detailed, and quite frankly, this is where the board exams love to test you. How do they actually get inside our cells?
The entry mechanism is remarkably similar for both families. They bind to specific receptors on the host cell surface. The cell is tricked into initiating receptor-mediated endocytosis, so it swallows the virus up in a little vesicle, an endosome.
And then the trap springs.
The pH trap, yes. As the endosome gets pulled deeper into the cell, the cellular machinery pumps protons into it, making it acidic. That sudden drop in pH physically changes the shape of those viral glycoproteins. It triggers a fusion event between the viral envelope and the endosomal membrane. The virus essentially melts right through the wall of the vesicle and dumps its naked RNA directly into the cytoplasm.
Okay, so now we are in the cytoplasm. We have this positive sense RNA floating around, and this is exactly where the roads diverge. This is the big toga versus Flavi showdown.
This is the core mechanism you really need to understand for exams. Let's look at togaviruses first. They are highly sophisticated. They use a two-phase translation strategy.
Two phases. So kind of like a morning shift and an evening shift.
Exactly like that. When the viral RNA first lands in the cytoplasm, the host ribosome can only read the very first part of it, the 5' end. That specific section codes exclusively for the non-structural proteins,
which are essentially the tools for the factory.
Right. The RNA-dependent RNA polymerase, the replication machinery. So phase 1 is simply build the factory tools. The virus makes the polymerase.
Okay, so the factory is built, the tools are ready, but now we need to actually make the car parts, the structural capsid and the envelope proteins to build new viruses.
But the problem is, the code for those structural proteins is buried way down at the 3' end of the RNA strand, and the host ribosome simply cannot get to it from the starting line. So the newly built viral polymerase does something incredibly clever. It takes the positive sense genome and makes a full-length negative sense template.
It makes a complete mirror image of itself.
Yes. And then, using that negative mirror image as a template, it starts printing out new positive RNA strands. But not just full-length genomes. It recognizes a very specific internal start site in the middle of the template and prints out a shorter, smaller piece of RNA.
Oh, the subgenomic mRNA.
The subgenomic mRNA. This little truncated piece strictly codes for the structural proteins, the capsid, and the envelope. And because it is small and distinct, the virus can churn out thousands and thousands of copies of it very rapidly.
So it is essentially a massive amplification step. It's the virus saying, okay, we only needed one blueprint to build the factory tools, but now we need 10 million blueprints for the car doors.
Correct. This strategy allows the virus to make massive amounts of structural protein very late in the infection cycle, right when it needs to package all the newly minted genomes. It is highly efficient, highly regulated gene expression.
That is genuinely smart biology. Now let's contrast that with the flavivirus, the yellow group. How do they do it?
Flaviviruses are, well, let's say they're a bit less elegant, but brutally effective. They don't do the whole two-phase thing. They don't use subgenomic mRNA at all. Their genome has one single open reading frame.
So the ribosome just hops on at the start and rides it all the way to the end without stopping.
It hops on at the 5' end and translates the entire genome into one single gigantic polyprotein.
Literally a giant sausage-like of protein.
A massive protein sausage. It contains the structural capsid, the envelope, the polymerase, the protease. Everything is all covalently linked together in one incredibly long chain.
That just seems really messy. I mean, you can't build a functional virus out of a sausage link.
No, you absolutely can't. So you need a butcher. This is where the proteases come in. The virus codes for its own protease, usually NS3, and it also hijacks the host cell's proteases in the ER. As this giant protein snake is being translated, it is simultaneously being chopped up into the individual functional proteins.
So Toga is tools first, parts later. Flavi is make absolutely everything it wants and chop it up with scissors.
Precisely. And there is one more vital nuance for flaviviruses. The structural genes, the capsid and envelope, are located at the front of the line, the 5' end, so they get translated first. The polymerase, which it desperately needs to copy the genome, is way at the very back, the 3' end. You have to translate the entire sausage just to get one single molecule of polymerase.
Which just feels incredibly inefficient compared to the Togavirus method. They're making all these structural parts before they even have the machine to copy the genetics.
It is less efficient, technically speaking, but obviously, given how terrifyingly successful dengue and West Nile are globally, it works well enough to cause massive disease.
Okay, so we've replicated, we have genomes, we have structural proteins. Now we need to actually assemble and get out of the cell. And this is the final major differentiator in the hardware section.
Right, the budding process. How do you actually exit the building? Togaviruses are extroverts. They go straight to the plasma membrane, the outer skin of the host cell. The viral envelope proteins insert themselves right there on the surface. The nucleocapsid pushes up against the inside of the membrane, wraps itself in it, and buds off directly into the outside world.
And usually, because they are doing this in such massive numbers, this process shreds the host cell membrane so much that the cell just dies. It's a cytolytic infection.
Yes, it essentially bursts the cell. Flaviviruses, on the other hand, are introverts. They don't go to the cell surface at all. They bud into internal membranes. Specifically, they bud into the endoplasmic reticulum and the Golgi apparatus.
Wait, so they bud inside the cell?
They bud into the hollow luminal space of the ER. So now you have a fully formed, enveloped virus just floating inside the cell's internal plumbing system. The host cell then treats that virus exactly like any other secreted protein, like insulin or an antibody. It packages it in a transport vesicle, ships it to the surface, and releases it via exocytosis.
So it literally tricks the cell into mailing it out.
Exactly. And this means flaviviruses can sometimes be released steadily without immediately blowing up and killing the cell, although eventually the cellular machinery just gets completely overwhelmed and the cell dies anyway.
Okay, that is a fantastic mental model. Let's recap that for the listeners. Toga is shrink wrap, two-phase, subgenomic mRNA, and surface budding. Flavi is the smooth golf ball, the single polyprotein sausage, and internal ER budding.
That is exactly the framework you need.
Perfect. So let's move on to section 2, pathogenesis, the host pathogen chess match. Let's say I get bitten by an infected mosquito. The virus is injected straight into my capillaries. What actually happens next?
The very first thing you experience, usually about 3 to 7 days after the bite, is the prodrome. You get a fever, chills, a pounding headache, back pain, and just profound fatigue. You basically feel like you have a terrible case of the flu.
Now, I know a lot of students automatically think, oh, the virus is destroying my tissue. That's why I feel so sick and tired.
But that is actually not true at all. At this early stage, the viral load in your blood is getting very high, but the symptoms are largely caused by you. It is your own interferon response.
Interferon alpha and beta, the innate immune system.
Right. When these RNA viruses replicate in your cells, they have to make double-stranded RNA intermediates. Our human cells absolutely hate double-stranded RNA. It is a massive molecular red flag that screams, alien invader. The infected cell senses this and just screams out, interferon to the surrounding tissue.
Which basically tells all the neighboring cells, shut down your protein factories, pull up the drawbridge, save yourselves.
And it also travels systemically and tells the hypothalamus in the brain to crank up the body's thermostat, giving you a fever, and it makes you want to just lie down in a dark room. This phase is called the primary viremia. The virus is circulating in the blood, and the innate immune system is throwing everything it has at it.
And honestly, for most people, this is the end of the story, right? You feel cruddy for maybe 3 or 4 days. Your neutralizing IgM antibodies finally show up, they clear the virus from the blood, and you go back to work.
Correct. The vast majority of these arboviral infections are self-limiting. But in the severe cases, the ones that show up on board exams and in the ICU, the virus escapes this initial containment. It creates a massive secondary viremia, and it uses the bloodstream to seed its preferred target organs.
And that target really depends on the specific virus.
Exactly. If it is West Nile or St. Louis encephalitis, the target is the central nervous system. They are neurotropic. If it is yellow fever, the primary target is the liver, so it's hepatotropic, as well as the blood vessels. If it is dengue, it targets the macrophages and the vascular endothelium.
I really want to spend some time on dengue here, because it has a totally unique and frankly terrifying pathogenic mechanism. We are talking about antibody-dependent enhancement, or ADE. This is the concept that always breaks students' brains because it completely implies that having immunity is actually a bad thing.
Yeah, it's incredibly counterintuitive. It's not so much that immunity itself is bad, it is that partial, cross-reactive immunity is dangerous. Here is the exact setup you need to know. Dengue isn't just one single virus. It actually exists as 4 distinct serotypes, cleverly named DENV1, 2, 3, and 4.
Okay, so let's run a scenario. Let's say I go to Thailand on my medical elective. I get bitten by a mosquito carrying dengue serotype 1.
You get classic dengue fever, breakbone fever. Your muscles ache, your joints hurt. You are utterly miserable for a week, but you recover. Over the next few weeks, your body makes beautiful, high-affinity neutralizing IgG antibodies perfectly tailored against serotype 1. You are now functionally immune to serotype 1 for the rest of your life.
Awesome. Sounds like my immune system did its job. Fast forward 5 years, I go to Brazil for a medical conference. I'm sitting outside, and I get bitten by a different mosquito. And this one is carrying dengue serotype 2.
And here's where the trap snaps shut. Your IgG antibodies from that first serotype 1 infection are still circulating in your blood. They bump into serotype 2 and they say, hey, structurally, that looks an awful lot like dengue. So they bind to it.
So they neutralize it. Problem solved.
No, they don't neutralize it. Because it's serotype 2, the shape is just slightly different. They bind to the virus, but it's a sub-neutralizing interaction. It's a cross-reaction. They stick to the viral particle, but they fail to actually block its receptor binding domains.
So now I just have a fully live infectious virus floating around with my own antibody physically stuck to the outside of it.
Yes. And this is exactly where the Trojan horse mechanism activates. Macrophages and monocytes, the big eaters of your immune system, patrol the blood. They have specific receptors on their surface called Fc receptors, specifically Fc gamma receptors. These are literally designed to grab the heavy chain tail, the Fc portion, of an IgG antibody. The macrophage sees this complex floating by and thinks, oh, fantastic, an antibody has captured some garbage. I will pull it in and digest it.
So the macrophage actively pulls the virus antibody complex inside itself via the Fc receptor.
It pulls the live virus right into the belly of the beast, but because the virus was never truly neutralized, it easily escapes the phagosome, it uncoats, and it starts replicating wildly right there inside the macrophage.
So my own antibody didn't just fail to stop the virus, it actually acted as a VIP pass, actively escorting the virus into the exact cell type it loves to infect.
Exactly. ADE acts as a massive viral amplifier. By exploiting your macrophages, you increase the viral load exponentially compared to a primary infection. And because the virus is now tearing apart your immune cells from the inside, those cells panic and trigger a massive cytokine storm. They just dump huge amounts of TNF-alpha, interleukin-6, and other inflammatory mediators into your blood.
And that cytokine storm is what causes the blood vessels to basically lose their integrity and become leaky.
Vascular permeability goes through the roof. The tight junctions between the endothelial cells break apart. Plasma physically leaks out of your blood vessels and third spaces into your tissues, your pleura, your peritoneum. Because you're losing intravascular volume rapidly, your blood pressure completely crashes. You go into hypovolemic shock. That is the pathophysiology of dengue hemorrhagic fever and dengue shock syndrome.
And it is almost entirely driven by the fact that I had that previous infection years ago. That is just wild. It's a literal double-edged sword.
It is, and practically speaking, it creates a massive, almost insurmountable challenge for vaccine development. If you make a dengue vaccine that only provokes a strong immune response against, say, 2 or 3 of the 4 serotypes, you haven't protected the patient. You might actually be predisposing them to fatal shock if they naturally catch that 4th serotype in the wild. You have to formulate a vaccine that induces perfectly balanced, strong, neutralizing immunity to all 4 serotypes simultaneously.
Wow. Okay, let's zoom out a bit to the epidemiology. We have talked about the arbovirus label, but we need to get very specific about the vectors. Murray is extremely clear about this. For the exams, you absolutely need to know your mosquitoes.
You do. We essentially have 2 main insect villains in this story. The Culex mosquito and the Aedes mosquito.
I always think of them as having completely different personalities.
Okay.
Like 2 different characters.
They absolutely do have distinct ecologies. Let's start with Culex.
Culex is the birdwatcher, right?
Right. Culex species, like Culex pipiens, strongly prefer to feed on avian blood. They feed on birds, they tend to live in temperate and tropical zones, and they love to breed in static, dirty water. We're talking sewage runoff, murky ditches, catch basins in the street.
So the really dirty, stagnant urban water.
Yes. And because they prefer feeding on birds, they maintain the virus in what we call a sylvatic or enzootic cycle, a bird-mosquito-bird cycle. The virus replicates to massive titers in the bird, which acts as the amplifying host. A Culex mosquito bites the infected bird, picks up the virus, flies off, and bites another bird.
Okay, so where do humans actually fit into that loop?
We don't. We are accidental tourists in the Culex ecosystem. Sometimes a Culex mosquito gets confused, or its normal bird hosts are scarce, so it opportunistically bites a human, or maybe a horse. We get infected. But, and this is a highly testable point, humans are dead-end hosts for Culex-borne viruses.
Meaning we get sick, but we don't spread it any further.
Right. Our human immune system keeps the viral load low enough that we simply don't generate enough viremia. There's not enough virus in our blood for a new uninfected mosquito to bite us and pick up a full infectious dose. The chain of transmission hits a brick wall and stops entirely with us.
So if I am in the ICU with severe West Nile encephalitis, I cannot give it to you if a mosquito bites me and then bites you.
Correct. The Culex viruses are primarily the encephalitis group. West Nile virus, St. Louis encephalitis, Japanese encephalitis. Birds are the reservoir, humans are dead ends.
Now let's meet the other villain, the Aedes mosquito, specifically Aedes aegypti and Aedes albopictus.
Aedes is often referred to as the cockroach of mosquitoes. It is incredibly highly adapted to human environments. Aedes aegypti doesn't like dirty swamps. It breeds in very small collections of relatively clean water. Flower pots in your balcony, discarded old tires, bird baths, bottle caps holding rainwater. It literally lives inside and around your house. And crucially, it is a day biter. It bites you while you're having a picnic, not just at night.
The aggressive urban day biter.
And unlike Culex, Aedes absolutely loves mammal blood. Specifically, it prefers human blood. This mosquito drives the transmission of the systemic and hemorrhagic viruses, dengue, yellow fever, Zika, chikungunya.
And for these particular viruses, humans are definitely not dead-end hosts.
No. We are the main event. In the urban cycle for these viruses, humans are the primary amplifying host. We generate incredibly high viremia. An Aedes mosquito bites you, gets a massive belly full of virus, incubates it, and then flies next door and bites your neighbor. You don't need birds. You don't need monkeys in the jungle. It is a purely human mosquito-human transmission cycle.
Which perfectly explains why you get these explosive, massive urban outbreaks of dengue and Zika that sweep through whole cities, whereas West Nile tends to be much more sporadic or seasonal.
Exactly. The ecology of the vector completely dictates the epidemiology of the disease.
Okay, let's get into the actual clinical syndromes now. We've set the stage, we know the hardware and the vectors. Let's talk about the specific diseases you will see on the wards and on the boards. We will start with the Alphaviruses, which are in the Togaviruses family, specifically the equine encephalitis.
Right. ENVE, Eastern, Western, and Venezuelan equine encephalitis.
I always appreciate these names because they literally tell you exactly where on the map to look.
ET, Eastern equine encephalitis, is the one you really need to respect. It is found along the Atlantic and Gulf coasts of the U.S. It cycles naturally in birds and Culeaceae mosquitoes deep in freshwater swamps.
But occasionally it jumps out of the swamp into horses and humans.
And when it hits humans, it is absolutely devastating. It has a remarkably high case fatality rate, sometimes approaching 50% in patients who develop severe encephalitis. And the ones who do survive often have severe permanent neurological damage. It destroys brain tissue.
Why do we call them equine viruses? Do horses spread them to us?
No, horses are dead-end hosts just like we are. But horses are highly susceptible sentinel animals. Very often, epidemiologists will see a sudden outbreak of severe encephalitis in local horse populations, a few weeks before the human cases start appearing in the ER. The horses serve as a very loud biological warning bell that the virus is active in the area.
Okay, staying with the alphaviruses, there's another major one, chikungunya. Also an alphavirus, but this one is transmitted by Aedes, not the swamp mosquitoes.
Chikungunya is a fascinating disease, and the name itself is incredibly descriptive. It comes from the Makonde language, spoken in parts of Tanzania and Mozambique, and it literally translates to that which bends up.
That which bends up. That just sounds incredibly painful.
It refers exactly to the physical posture of the patient. The absolute hallmark of chikungunya is debilitating polyarthralgia, severe acute joint pain. It is so intensely painful that patients literally walk stooped over or they can't get out of bed at all.
Clinically, how do you actually tell it apart from dengue? Because they are both transmitted by the exact same Aedes mosquito, they both occur in the tropics, and they both present with high sudden fever and a maculopapular rash.
The pain profile is the key differentiator. Dengue is break-bone fever. It causes deep, severe myalgias and bone pain. You feel it in your large muscle groups and your back. Chikungunya is primarily joint pain. You see profound swelling, stiffness, and exquisite tenderness in the small joints like the hands, the wrists, the ankles. Also, chikungunya is miserable, but it rarely kills you, whereas dengue, as we discussed, can progress to hemorrhagic shock and death.
Okay, moving across to the flaviviruses, let's do the encephalitis group first. West Nile virus.
West Nile is a phenomenal historical case study in epidemiology. Let's go back to 1999, New York City. It was an unusually hot summer. Out of nowhere, elderly people started coming into emergency rooms in Queens with severe encephalitis, muscle weakness, profound confusion, fever.
And initially, the health department thought it was just St. Louis encephalitis, right?
Yeah.
Because that is a known endemic U.S. virus.
Right, they assumed it was SLE. But at the exact same time, and this is why the concept of One Health, connecting animal and human ecosystems, is so vital, crows were dropping dead all over the Bronx Zoo.
Like literally just falling dead out of the trees.
Literally falling out of the sky. A veterinary pathologist at the zoo, Dr. Tracy McNamara, noticed this and realized that whatever was killing her birds might be biologically related to the humans dying in Queens. St. Louis encephalitis does not kill birds. It just uses them as a reservoir. So she pushed back and sent tissue samples to the CDC. Sequencing proved it was West Nile virus, a pathogen that had never, ever been seen in the Western Hemisphere before.
And from that initial foothold in 1999 over the next 4 or 5 years, it basically swept completely across the North American continent.
It hitched a ride in migrating birds and moved westward every single season. Now it is completely endemic in 48 states. It is just a permanent part of our ecosystem now.
Clinically, if a patient comes in, what are we looking for?
So the vast majority, about 80% of infected people, are entirely asymptomatic. They never know they had it. About 20% develop West Nile fever, which is a self-limiting flu-like illness. But roughly 1 in 150 people, particularly those over the age of 50, develop neuroinvasive disease, meningitis, encephalitis.
And there's a very specific presentation that can easily be mistaken for polio, right?
Yes, acute flaccid paralysis. The virus has a tropism for the anterior horn cells of the spinal cord, exactly like poliovirus. If you see an older adult in the ER in late August with fever, altered mental status, and a completely floppy, paralyzed arm or leg, West Nile should be at the very top of your differential.
One really important safety note here for medical practice: blood transfusions.
Crucial point. Because of the brief but significant viremia, West Nile can absolutely be transmitted via blood transfusions and solid organ transplants. Since 2003, essentially all blood donations in the United States are mandatorily screened for West Nile viral RNA.
All right, let's pivot to the hemorrhagic and systemic flaviviruses. Dengue, yellow fever, Zika.
We already covered the terrifying ADE mechanism of dengue, but clinically, on the wards, watch for the saddleback fever. The patient has a high fever for a few days, it breaks, and they feel a bit better for a day, and then it aggressively spikes right back up. Also, severe retroorbital pain, feeling like someone is pushing on the back of their eyes, is a classic dengue symptom.
And there's the tourniquet test.
Yeah.
I have personally never seen this done in a modern hospital,
Mhm.
but it is in literally every single textbook.
It is an old-school, low-tech way to test for capillary fragility at the bedside. You take a standard blood pressure cuff, inflate it halfway between the patient's systolic and diastolic pressure, and you just leave it there for 5 agonizing minutes. Then you release the pressure, and you literally count the petechiae, the tiny red microhemorrhages on the forearm. If there are a lot of them, usually more than 10 to 20 per square inch, it physically proves that the blood vessels are leaking under pressure. It is a major clinical warning sign that the patient is progressing toward dengue hemorrhagic fever.
Next up is the namesake of the whole family, yellow fever.
Yellow fever is a visceral, historically terrifying disease. Unlike dengue, which targets the vasculature, yellow fever specifically targets and destroys the liver. It is highly hepatotropic.
Hence the profound jaundice, the yellowing of the skin and sclera.
And critically, the coagulopathy. Your liver manufactures almost all of your essential clotting factors. When the virus causes massive hepatic necrosis, you simply stop clotting. You bleed spontaneously from the gums, the eyes, the nose, and you bleed heavily into your gastrointestinal tract.
Which leads to the famous horrifying clinical sign, black vomit.
Hematemesis. The acid in the stomach digests the pooled blood, turning it dark and granular, so the patient vomits up fluid that looks exactly like black coffee grounds.
If I am a pathology resident looking at a liver biopsy from a yellow fever patient, what is the high-yield buzzword I need to know?
Councilman bodies. These are individual hepatocytes, liver cells that are actively undergoing apoptosis, cellular suicide because of the viral infection. Under the microscope, they look like these shrunken, intensely eosinophilic, bright pink globules scattered throughout the liver tissue.
But despite how awful it sounds, there is actually phenomenal news when it comes to yellow fever.
The best possible news. The 17D vaccine. It was developed back in the 1930s by Max Theiler. It is a live attenuated viral vaccine. One single shot gives you essentially perfect, lifelong immunity. It is widely considered one of the single most effective and successful medical interventions ever created in human history.
Finally, in the Flavivirus group, the relative newcomer, Zika.
Zika obviously appeared on the world stage in a massive way in 2015 and 2016, mostly centered in Brazil. Now, in healthy adults, it is usually incredibly mild. Low-grade fever, a faint rash, and red eyes, conjunctivitis. Many people don't even notice they are infected.
But the virus has a very specific tropism and affinity for neural progenitor cells, the stem cells that build the brain.
Right, and that is exactly why it is so devastating for a developing fetus. If a pregnant woman is infected by a mosquito, the Zika virus can easily cross the placental barrier and aggressively attack the developing brain tissue of the baby. It physically halts the brain from growing and dividing.
Causing microcephaly.
Yes. An abnormally small head with collapsed skull structure, leading to severe, lifelong cognitive and physical impairment. It is a tragic outcome.
And unlike literally all the other arboviruses we have discussed today, Zika has a very dark party trick. It can be sexually transmitted.
It can. The virus has a specific affinity for immune-privileged sites. It hides out in the testes and can persist in seminal fluid for months after the infection has completely cleared from the patient's bloodstream. So men who travel to endemic Zika zones need to use barrier protection for several months after returning, even if they feel completely fine, to protect their partners.
Okay, we have trekked all the way through the jungle and the swamp. We have fought off both Culex and Aedes mosquitoes. Now we finally have to deal with a grand exception. The virus that is genetically a togavirus, but absolutely refuses to act like one, Rubella.
The odd one out. It sits in its own genus, Rubavirus.
So why is it even classified as a togavirus if it has absolutely nothing to do with bugs or arboviral cycles?
It comes down to purely molecular taxonomy. If you look at the genome, it has the exact same structural layout. It uses the exact same two-phase translation strategy with the subgenomic mRNA we talked about earlier. And under the microscope, it has that exact same shrink-wrap morphology. But ecologically, it is purely a respiratory pathogen.
So no vectors at all, just coughing, sneezing, and breathing.
Humans are the sole natural host.
We commonly know it as German measles or three-day measles. How do we clinically distinguish it from regular measles, which is rubeola?
Generally speaking, postnatal rubella in a child is much milder than rubeola. They get a low-grade fever. Their rash looks visually similar. It's a pink maculopapular rash that starts on the face and spreads downward over the body, but it clears up much faster, usually within 3 days. But the real key finding, the absolute dead giveaway for the board exams is the lymphadenopathy.
Where specifically should we be feeling for swollen nodes?
Postauricular, right behind the ears, and suboccipital, right at the base of the skull at the back of the neck. If you have a mildly sick child with a descending rash and tender bumps behind their ears, you need to immediately think rubella.
Now, in adults, it actually presents slightly differently, right?
Yes, especially in adult women. They very frequently develop significant arthritis and arthralgia along with the rubella infection. It can mimic the pain of acute rheumatoid arthritis for a few weeks before resolving.
But just like we saw with Zika, the real clinical story isn't the infected adult. It is the immense danger to the fetus.
Rubella is the R in the torch infections. It is an incredibly potent teratogen. If a woman contracts a primary rubella infection during her first trimester of pregnancy, the risk of the baby developing congenital rubella syndrome, or CRS, is overwhelmingly high.
What exactly does CRS look like? When I was in med school, I had to memorize the classic triad.
The classic triad is highly testable. Number 1, cataracts leading to early blindness. Number 2, profound deafness, specifically sensorineural hearing loss. And number 3, severe cardiac defects.
Which heart defects specifically should we look for on an echocardiogram?
Patent ductus arteriosus, or PDA, is the classic board-style answer. You might also see pulmonary artery stenosis. The easy way to remember the triad is simply eyes, ears, and heart.
And there is a very specific, visibly striking skin finding in these completely overwhelmed newborns, too.
The blueberry muffin rash.
Which sounds completely harmless and cute, but it really isn't.
It is definitely not cute. Pathologically, it represents dermal extramedullary hematopoiesis. Because the fetal bone marrow is either completely failing or overwhelmingly suppressed by the virus, the baby's body desperately tries to manufacture new red blood cells directly in the skin tissue. Those dark blue and purple spots all over the baby are literally little islands of ectopic blood production. It is a sign of profound systemic distress.
So how do we prevent it?
The standard MMR vaccine, measles, mumps, rubella, it is a live attenuated viral vaccine, and it works wonderfully.
But that brings up a critical, absolute contraindication that every medical student has to know.
You absolutely cannot give a live attenuated vaccine to a pregnant woman. The theoretical risk of the live vaccine strain crossing the placenta and harming the fetus is just considered too high. So the public health strategy is test women's rubella titers before they ever get pregnant. If they are not immune, you vaccinate them immediately and instruct them to wait at least 4 weeks before attempting to conceive. You want to completely close that window of vulnerability before the pregnancy even begins.
Okay. Wow. That was a serious marathon. We have covered the molecular hardware, the 2 distinct vector ecologies, the complex pathogenesis, and the specific clinical syndromes of 2 massive viral families.
Yeah, it's a lot of material. We need to see if any of it actually stuck with the listeners.
Agreed. It is time for the deep dive quiz. I'm going to throw out a clinical vignette. You at home have about 5 seconds to shout the answer at your windshield, or, just whisper it quietly to yourself in the library. Then we will explain the why.
Let's do it.
Question 1. A 28-year-old man returns from a trip to Southeast Asia. He develops a high fever, severe back pain that he says feels like his bones are breaking, and intense pain behind his eyes. A tourniquet test in the clinic comes back positive. Which specific cellular receptor mechanism is responsible for the severe complications associated with a secondary infection by this exact virus?
The answer is FAC receptors on macrophages. The virus is, of course, dengue. The breakbone fever and retroorbital pain are the classic clues. The severity of a secondary infection is driven by antibody-dependent enhancement, or ADE. Those non-neutralizing antibodies from a past infection actively help the new virus enter the macrophages via their Fc gamma receptors.
Question 2. A 6-year-old girl is brought into the clinic with a pink rash that started on her face yesterday and is now spread down to her chest. Her temperature is 99.5 Fahrenheit. On physical exam, you easily palpate tender lymph nodes behind her ears and right at the base of her skull. Which viral family does this pathogen belong to?
The answer is Togaviruses. The clinical diagnosis here is rubella, the German measles. The key clues are the rapid descending rash and that specific post-auricular and suboccipital lymphadenopathy. Remember, rubella is a togavirus, specifically the genus Rubivirus, even though it is completely distinct from the arboviral life cycle.
Question 3. It is September in New York City. A 65-year-old man is brought to the ER with acute confusion, a high fever, and a noticeable tremor. His daughter mentions he spends basically all day outside gardening. An MRI shows inflammation of the basal ganglia and thalamus. CSF analysis confirms a viral etiology. What is the primary ecological reservoir for this specific virus?
The answer is birds. The patient almost certainly has West Nile virus. He is an older adult presenting with encephalitis in late summer. West Nile is a Flavivirus transmitted by the Culex mosquito. The natural amplifying reservoir is local bird populations. Humans are just accidental dead-end hosts.
Question 4. You are working late in a virology lab. You have just isolated a virus that replicates by translating its entire positive sense RNA genome into one single, massive long polyprotein, which is subsequently cleaved by proteases into functional parts. Which viral family does this likely belong to?
The answer is Flaviridae. This is the classic sausage link translation strategy. Togaviruses use that more complex two-phase strategy with the subgenomic mRNA. Flaviviruses just make the one single giant polyprotein.
Question 5. A neonate is noted to have dense cataracts, a continuous machine-like heart murmur, and unfortunately fails their newborn hearing test. The mother recently emigrated from a country with very low vaccination rates during her first trimester. What is the most likely specific cardiac defect causing that murmur?
The answer is patent ductus arteriosus, or PDA. The classic triad of cataracts, deafness, and heart defects strongly points to congenital Rubella syndrome. PDA is by far the most common cardiac anomaly associated with CRS.
Question 6. A patient living in a rural jungle region of South America dies of fulminant liver failure after a biphasic illness involving severe jaundice and hematemesis. The autopsy reveals eosinophilic apoptotic bodies scattered throughout the liver tissue. Which specific vaccine could have prevented this entire tragedy?
The answer is the live attenuated 17D vaccine. The disease is clearly yellow fever. You have the jaundice, the black vomit hematemesis, and the classic councilman bodies on pathology. The 17D vaccine is the highly effective, specific preventative measure for this virus.
How did you do out there? If you missed the molecular replication ones, I highly recommend going back and looking directly at the diagrams in Murray Chapter 52. Specifically, trace your finger along the difference in how the togas and flavus make their structural proteins.
And just before we close out today, I want to leave you with a broader thought. We have spent a lot of time today talking about tropical medicine, swamp viruses, exotic jungle pathogens.
But the reality is the world is getting fundamentally smaller.
And it is getting warmer. The geographical habitat for Aedes aegypti and Aedes albopictus is physically expanding northward every single year. Mosquitoes do not respect international borders. We are already seeing locally acquired dengue cases in Florida and Texas. We're seeing chikungunya outbreaks in Italy.
So these chapters in the back of the textbook, they aren't just for people planning to do global health work in the Amazon anymore.
No, absolutely not. They are essential knowledge for anyone practicing clinical medicine in the 21st century. The very next patient who walks into your local ER with a sudden fever and a rash might not have traveled anywhere at all. The infected vector might be breeding right in their own backyard.
On that slightly ominous but incredibly important note, thank you for taking this deep dive with us.
Leap learning, keep reviewing. We'll see you next time.